And this session is going to be on lessons in hemostasis and thrombosis we have learned from COVID-19. And Michael Paidas is going to start talking some on kind of preclinical models in terms of how we can better understand this. And then Lisa Baumann Kreuziger on clinical care and guidelines. Michael is professor and chair in the Department of Obstetrics, Gynecology, and Reproductive Sciences, the Miller School of Medicine at the University of Miami, and chief of service, University Health Tower and Jackson Health System. He is a maternal-fetal medicine clinician scientist specializing in reproduction, placenta-mediated complications, and hemostasis, with activities spanning direct patient care, translational research, and clinical trials. Michael.
Thank you, Barb. Thank you, Andy, and the Foundation for the invitation to be here. Super glad to be here and amongst friends. Get this right. Okay. Okay. Barb, maybe a little help for a minute on the, yeah, let's try this. Okay, all right, got it. Okay, thanks. So what I'm going to describe for you today is our foray into trying to advance COVID, both the understanding in animal models and our therapeutic. So I'm going to give you our story for this, and hence the title, Preclinical Model and our COVID therapeutic. And these are my disclosures. They mostly relate to the COVID work and brain injury, because I will tie the brain injury in at the end. So we're going to talk about this. First, I want to give an acknowledgement, a huge acknowledgement, to my collaborator, co-inventor, intellectual contributor, and laboratory director for my lab. So while I was dealing with the 6 waves of COVID on the front lines in clinical, Dr. Jayakumar was manning the lab about that. So couldn't say enough about all his great work. And we know that COVID, has dominated our experience, a huge crisis. And what I just want to point out to everyone is that, we're particularly interested in the vulnerable population. So for pregnancy, it's 213 million women, and for children under age 18, 2.2 billion. And for most of all of this, we've had one drug that's been used to treat COVID, and that's with limitations, so the remdesivir. So that was an impetus, and no treatments for long COVID. So, and this issue about the lack of therapeutics has been, sounded in Bill Gates and the Times, and you all know this, and the long-term outcomes of COVID, they're certainly important. And on a personal note, we had the spouse of the first patient in Miami with COVID, and so we were on the front lines after New York, and then I lost a very dear colleague of ours in OBGYN before we had really anything, and we learned a lot from this experience, and it was quite sad and traumatic for everyone, as many of you experienced. So the moment, a few weeks into COVID, I had the idea that, and I looked back on my experience with CMV, and I said, you know what, we're gonna go after COVID, and from our work with CMV, we targeted preventing CMV from entering the cell. So I knew exactly what I wanted to do, and we went ahead and tried to design this, and so we went after the spike protein, and so basically, in a nutshell, what happened is we started out with very sophisticated image modeling, and then we went into protein docking, molecular dynamics, spectroscopy. We modeled several peptides that would cover the spike protein, the receptor binding domain of the spike protein that is, let's see here, oops, sorry. here, and this is the ACE2 binding site where we know the spike is binding, and basically we knew the human, and we wanted to establish an animal model, and which we did, a murine hepatitis virus model, which is a coronavirus, and it mimics and now we think replicates really clinically COVID quite well. And in terms of how we performed, we took the best peptide, and this is a spectroscopy data. I don't expect all of you to appreciate all this, but let me just tell you that our leading candidate, which we called SpikeNet because it is draped over the spike protein, it has a very high binding affinity, which is listed here. And to this day, I think it's the most tightly bound molecule to the spike protein. And so, and this spectroscopy data is evidence of that by looking at this shift. And in the interest of time, we'll let that be. So then, very importantly, and I'm giving you sort of the data on the development of the therapeutic as well as with the animal model. I'm going to show you in a second. But we had to do some studies to prove that the binding of the peptide was unique to the spike protein, to the receptor binding domain, and not to actually binding the receptor, not the ACE2 in the human, and also not in the mouse equivalent, which is the CCAM over here. So you see that these lines diverge. There's no close binding, whereas over here, they're very closely knit together, indicating tight binding. So we knew that we were on the right track. And so then, on the advice of someone at NIAID, they suggested you might want to develop this murine hepatitis model, which we went ahead and then have been studying. And then we published the use of our therapeutic in that model. And just to point out, some of the personal aspects of this. The first author of really a great review, if you're interested in animal models for COVID, is Luis Caldera Crespo. This is the son of Dr. Caldera, who succumbed to COVID, and he spent nearly a year with us and continues to work. So you can see the motivation, to address COVID. So, okay, so this is a thrombosis hemostasis meeting. And the reason why I suggested to Andy, and I guess in a moment of weakness, she said, okay, you can go ahead and do this. But maybe it's a little hard to see with the lights, but one of the reason why I got so excited about the model, among other things, is and when you look at the tail here in the middle, you can see clear evidence of thrombosis. Maybe you can see at these dark patches here. This is the actual thrombosis in the tail. And the salient features for this model are about three things, basically. One is, it's a pretty good harsh phenotype for COVID, in the sense that if you look in this middle panel down here, you'll find that over time, many of these animals, if they're not treated, they die. So that's one thing. So it's significant, as what we were seeing clinically. Patients often, if they're not surviving the first 3 to 5 days, it's not so good. Also, the animal weight. So these animals lose weight pretty dramatically. And then clinically, also, what we were seeing, as you were as well probably, is that there's overwhelming amounts of edema that you're seeing, and that's correlated when you look at the wet to dry ratio. So the animals that are infected, there's more water rate, and then we can reverse that with the therapeutic. And then the pictures are just the controls in panels over here, and then the sicker animals, and then the treated ones. So in the midst, while we were trying to get this all published and moving this along, there was always, it's not the actually transgenic model for COVID, and this is why, so the reason why I was happy about pushing for the model that we developed, one is it really does replicate COVID, in my estimation, pretty well. But the other is it's a BSL-2, whereas when you're working with COVID, the SARS-CoV-2, et cetera, it's BSL-3 or and above. We didn't have this model, we didn't have this facility near our area, and there's not many across the country. So I shipped the peptide to northern Arizona, and they essentially administered. And the dosing, just to understand, this is not only true for the MHV. Basically, we're talking about giving 3 doses very early on, like every other day, similar for this. And when I show you the long-term data, we followed the animals for long COVID for a year, and similar, just a few doses. So in other words, your shot is to get them treated early, up front. And if it doesn't work then it's not so good. So anyway, we had good survivorship, in this model. So this was, we were bolstered by this data in a second model. Now, so again about, what are you seeing? And I will tell you across the board, when you start looking, I'm going to share with you some of the immunohistochemistry and some of the H&E stainings and other work that we did. But there's a general pattern that we're seeing, and one reason why I think the model is good to look at. So what you're seeing on this slide is the organs: kidney, heart, lung, liver, the infected, and then the treated with the spike net. And on the right is the brain, both the cortex and hippocampus. And just to say that the mouse model replicating the COVID-19 is basically filled with congestion, and there's evidence of thrombosis that you're seeing here. There's vacuolization, and even if you just, a good one to look at is the lung. This is normal lung. This is treated, looks pretty normal. And here you can see all the congestion and thrombosis here. There's also apoptosis also going on. So, and it's a general theme. Then we can also look at some analytes. I just shared with you one on the liver, and there's major dysfunction in the infected animals, and then the treated animal on the right doesn't quite normalize, but it's vastly improved. Now, being an obstetrician, we tend to think very simply. And when we're seeing patients, we're thinking, okay, these patients, there's a lot of water, fluid. What are we doing with all this? So we thought, well, why don't we look at the water channels? So there's a group of important water channels, ubiquitous channels called aquaporins. And on the right is the cartoon of these. And so they regulate much of water passage. And just to give you a sense, I will say up front that we're still trying to understand the data that we are finding, but I will tell you that when you look at a selection of the aquaporins and you look at the different organ systems here, and the paradigm is you have controls, infected, and then infected treated with the different aquaporins. And generally speaking, the treated animals are favoring back to baseline. If you look at the graphs on the right, this is your baseline controls. So you see, generally speaking, there's increased fold change with the infection and a regression toward normal. It's not all, they're not always all in the same direction. We're still trying to figure out the roles of the different aquaporins in the different tissues. But there's something clearly awry going on with the aquaporins. So once we had the survivorship, the weight improvement, so then we thought, well, could we do anything else with the peptide? Could it be helpful? And so also, again, thinking that, there's a lot of inflammation associated with this, so maybe we should look at whether our therapeutic would have any effects on inflammation, on reactive oxygen species, etc. And it turns out that, and here's an example for 4-H&E and MDA, and again, the peptide really does seem to improve oxidative stress. And you can get a little bit more involved, and you can look at protein carbonyls. We've looked at LPS. We've looked at, and in this case now, just switching gears for a moment to show you, here because we were very interested in the brain aspect of things, we were looking at this part is cell culture. The other was actually the animal data, but this is the primary cell culture, both astrocytes and microglia. And all along the way, you see an improvement, regression back to normal, or even in some cases, even if you look down here, where you look at oxidative stress, it actually even is helpful just treating the cells by itself. So there's some inherent benefit. And then, another area that we were interested in is what about replication? This was something that was very important to me in CMV, in that we were able to reverse with a different therapeutic, but we can reverse many of the effects. But what was happening, and it might be a little hard to see with the lights, but let me just assure you and tell you that these are basically on the left, this is lung infected and treated, and this is brain infected and treated. And this is the nuclear staining here, and then the nucleocapsid. So the nuc and the S1 are evidence of the virus. And when you merge these, what you find in the lung infected, there's an awful lot of virus here. But in the treated, you find very few. You can see this like one little area here, one here. Whereas, and the same is true in the brain as well. So we definitely were impacting the replication. So moving along then, we thought, well, let's look at long COVID. We were getting signals that, this is really an important area and what to do. So we patiently, followed these animals. So they were infected, some were treated, and then we followed both the treated and the untreated for a very long time. And what you see here in the weight aspect is that, so here is the treated right in the middle. This is our control, and these are the infected, untreated. And so we see an improvement with the treatment, not quite back to normal, but definitely making it. And then another way to look at it is, what about their disease stages? What happens with these animals? And so you can see that, and if you're up here, this is bad. This is near death up here. So you see that the model establishes they get pretty sick, but there are some that survive, of course, and the ones that are treated. But then you can see, like in a year out, basically the untreated are still at around stage 2, and the SpikeNet treated are down here. But there's more to this story. And the story is that when you look at the tissues, what you find is that they're not normal, even though that they are alive. And so it might be a little hard to see the names, so I'm going to just show you. So this is lung right now, and this is control, right? This is the infection after 7 days. This is infection without treatment at 12 months. You can see clearly these are not normal. But here is treatment, 7 days, and here's treatment at 12 months. So they look pretty good compared to the untreated. Then you could look at the brain. The brain findings are pretty fascinating themselves as well. They're really not normal at all. The control is here on the left. You have the gray and then the white matter. You see a whole lot of vascularization. You see thrombosis. Both you see it in the 7-day and at the 12-month mark. And the treated ones here with SpikeNet, they're better. They're not quite completely normal, but they're better. And then if you want to see this a little bit better, these are all infected high magnification brain, and here you see the thrombosis over here. So not normal. So the message is people, animals, they're recovered, but they're not over all of this. And then, so to get a little bit more, we started to continue to pursue the brain aspect of things, and here we're looking at astroglia and activated microglia. And basically, the way to look at this is the infection causes a whole lot of astrogliosis and a lot of activated microglia, but the treated are almost nearly reversed, completely back to normal. And we started looking and wondering if there's a long-term effect. Maybe we should start thinking about chronic neurologic diseases. So we kind of got into like the Alzheimer's and chronic neurologic conditions and started looking at markers. And the two, one is a synaptophysin. This is a presynaptic microtubule. So all this red down here, this is all good stuff. And then you can see the virus. It's like a disintegration of the microtubule formation. And then you see the reversal, or not quite complete, but a good reversal. And the same is true for tau. And then some other findings which we just presented, but we're still learning about, is we started looking at surfactant. It turns out that there is evidence of surfactant in the brain, which we didn't appreciate. So that's a new finding. And also we started looking at NMDA receptors because they've been in the lung and the brain in particular. And they're very important, and in severe inflammatory infections. So we're still trying to piece the story together, but there's something to the data on this. And this is one of the reasons, if you have a virus in a model that you really can't study, how are you going to tease this all apart? And how can you really do this in the human well? Anyway, so this is more on this to come. And then, I'm going to just end with the clinical piece. So we had the Miami COVID project, and we identified typical and some novel, markers associated with maternal placental fetal transmission. And we made some correlations with one of the abnormalities that we see in the placenta, fetal vascular malformation, in maternal IL-6 levels, having a prediction for all that. But I'm going to just leave you, this is my last slide. This is a study that's in press now in pediatrics. And these two cases are really, for me, they're changing the landscape about COVID. So we had two patients on our service, both had second trimester COVID. One, very severe in the ICU. Unfortunately, at 13 months, the baby succumbed. And we documented, and that's what this case report for these two cases are, clear evidence in the placenta, and then the brain malformations, and which essentially replicate hypoxic ischemic encephalopathy, and we documented for the first time COVID in the brain. And so now you ask, well, what is all that animal work? Why is that? I'm convinced that all of that meticulous work in the animal helped us to actually get to the part of being able to find this. So now we've proved conclusively that the virus is in the brain in this affected baby who's otherwise had a complete workup for any other explanation for this. And the other case is an ongoing, but a very sick baby, unfortunately, with a lot of brain atrophy. That's the second case here. So this, to me, it's a cautionary tale that maybe it's rare, but we now have the evidence that clearly a maternal infection infects the placenta and affects the baby, and there's severe infection at the uteroplacental interface, and we can document it now. And then we have some other analytes that go along with the story on the bottom. So, so with that, I would just conclude by saying, I think, you know, the animal models are not the answer to everything, but this is a murine model that can be helpful in studying COVID. I hope we move the bar continually. We need therapeutics, and one way to look at a therapeutic is to attack the spike protein, and there's some other added features that will help us, and we're now studying it. We have an agreement with NIAID to study for long COVID potentially, and so the work continues, and I hope we make progress to finally get to a therapeutic for our vulnerable population of our pregnant and our child and adolescent patients. Thank you for your attention. And I just want to thank my lab, and there's other folks involved, but special thanks to Dr. Jayakumar. Thanks for your attention.
Great. Thank you, Michael, for that very intriguing data. And now I want to welcome Lisa Baumann Kreuziger, who will talk about clinical care and guidelines. She is investigator at the Blood Research Institute University and associate professor at the Medical College of Wisconsin. She specializes in non-malignant hematology with an emphasis in thrombosis, and she's the medical director of the Anti-Thrombotic Therapy Management Program at Frederick Hospital, where she leads quality improvement projects involving anticoagulation. And she will probably share with us, but I wasn't given that. I know that she's been involved in a number of guidelines in COVID and thrombosis, so we have the expert with us. So welcome.
All right, thank you. So yes, I will disclose. So I don't have any financial disclosures, but I have a couple of pretty important intellectual disclosures. One is that I have had institutional research support, both from NHLBI as well as Invent, for some of the COVID anticoagulation trials that I'm going to talk with you about. And then I am a member of the NIH COVID-19 guideline panel, which has definitely influenced my ability to give this talk and learn so much from all of the members of that panel. So a couple of learning objectives. So I hope you can recognize the breadth of the clinical trials that we've done that have already been completed in 3 years or less in antithrombotics for COVID-19. And then I want to maybe push the field a little bit and talk about some of the benefits and drawbacks of some of the clinical designs of those trials. So this was titled kind of lessons, so I'll kind of frame it in that way. So the first lesson I want to talk through that maybe we should have known and maybe did prior to COVID, but infectious diseases are prothrombotic. So really, we understand this, and especially, Dr. Paidas talked about the, CMV, but we also knew this in our sepsis patients and patients hospitalized in the ICU. So this is a chart that overviews kind of prior randomized control trials looking at the incidence of venous thromboembolism in critically ill patients, and the range is there between 6 and 16%. But if we look at a very specific group of ICU patients, because we know that our ICU patients are not all the same, so if we look at those just with sepsis, the rates are much higher. So pulmonary embolism in 3.5%, proximal DVTs at 11%, many upper extremity DVTs because we put lines in patients, and overall, if we're looking for all of venous thromboembolism, up to over a third of patients having a venous thrombotic event. So this provides a little bit of a background of the comparative cohort of what we should have understood and expected for patients with COVID. So early in the COVID-19 pandemic, we did have a lot of publications, most of them retrospective, one prospective study in here, two looking and reporting the incidence of VTE in our patients. And you can see the pretty significant range here, anywhere from 7.7% all the way up to 47%. And what I did here also is then just put lines where previous randomized control trials of all ICU patients have been versus that sepsis cohort. So, our incidences here fell in line with what we have and should have expected otherwise. When we look at meta-analyses of ICU patients, it does tend to be a little bit higher in about a third of patients. And really, the other things to think about is that depending upon the time that these studies were done, early in the pandemic, an ICU patient could have been housed anywhere in the hospital, and what were the criteria, whether it was, in a massive place where there's a huge spike versus not. What other treatments were going on? We've learned a lot about the need for anti-inflammatories and dexamethasone in the treatment of COVID, and that has definitely influenced our incidence of VTE as well. And then there was a huge difference in threshold for testing between sites and also between the phases of the pandemic. Early in the pandemic, you couldn't get a patient down for a CT scan. Like, they weren't going to move a patient with COVID down to the scanner. And so that was very different than later on in the pandemic, where we were able to do those imaging tests. And that was highlighted in this meta-analysis here too, that really looked at the incidence based on if screening ultrasounds or CT scans were used. And so if there weren't any screening scans that were used, 9.5% VTE incidence, if screening scans were used at 40%. So there definitely are a lot of asymptomatic VTE events that were being diagnosed. So lesson number 2, motivated people and funding equals expedited answers. So we got through trials faster than I think we've ever done before in COVID. And it really was this combination of having people that were willing to do this prior to funding even starting, expecting funding would come, and then having that then moved the field forward very quickly. So I'm going to talk through each of the areas in which we've done clinical trials, anywhere from diagnosis and then moving along in the patient course throughout here. So we'll start with diagnosis and looking at the antithrombotic trials with that. And instead of walking you through each of these studies in turn, I'm just going to summarize the results of those studies. And each of the slides is going to look very similar, so I will walk you through it. So each of the studies is going to be listed here in a column, and then talking about each of the outcomes there in the rows. So when there has been no statistical differences between the comparators, there's an equal sign. If there's a benefit, it's in green in the direction that it would be expected. If there's a harm, it's in red. So the Active 4B study is a study that I was involved with one of the networks involved in that study. And then that study looked at apixaban in prophylactic or therapeutic doses, or aspirin, versus placebo, whereas the OVID and the ETHIC studies really looked at low molecular weight heparin. And at a glance, what you can see is it didn't help. Antithrombotic therapy did not help at diagnosis to prevent hospitalization, survival, or thrombotic events in these patients. What we did see in the Active 4B study is that for therapeutic anticoagulation with apixaban, we saw an increase in major bleeding. So the interpretation of this results is that really we should not be treating people at diagnosis with anticoagulation or antiplatelet agents to prevent any of these events. So let's move on to patients who progress to needing hospitalization, either on the ward or in the ICU. So here are the studies of the non-ICU patients, and this is all in adults. Sorry to the pediatricians in the rooms, we do not really have randomized trials, unfortunately, very much in children. So for adults, what we do have in the first column there is the multi-platform study. So not only with the Active-4 trial, which used multiple different networks within the United States, we then combined efforts with the attack group, which is primarily in Canada and some in the US, and then the REMAP study, which is primarily in the UK. And we all looked at heparin and compared prophylactic to therapeutic dosing and determined if there was a difference in outcome, really looking at do people progress to needing ICU care. So that was the impetus for both the multi-platform study here and the RAPID trial. The HEP-COVID study really did look at thrombosis, and then the ACTION trial looked at rivaroxaban for the same purpose. And what you can see here is that there was benefit. So the multi-platform study did meet the primary endpoint there and showed that therapeutic heparin led to less organ support being required for patients who received it. It did not show a survival benefit and did not have an impact on thrombosis. The RAPID trial had a survival benefit shown, and the HEP-COVID study showed a decrease in thrombosis, and that's really what drove their primary endpoint. The ACTION study did not. And so this provides some very interesting thoughts of, is there a difference in the mechanism between heparin and rivaroxaban in prevention of worsening of COVID-associated disease? What we did see with the ACTION trial is an increase in major bleeding, and that is primarily thought secondary to the fact that they extended the treatment out of the hospital for 30 days. So the interpretation here and what all of the guidelines, not only the NIH guidelines, have now suggested is that therapeutic heparin is recommended for hospitalized non-ICU patients with COVID-19 in order to prevent progression of their disease. One last thing, the FREEDOM trial, just a note, that was just presented earlier this week. It was the same design as far as therapeutic versus prophylactic dose of heparin. And that was also shown to be beneficial. It's only been presented in abstract form, so we're looking forward to seeing the actual paper of that too. So that will be making the news here very soon. Switching gears to ICU patients with COVID-19, this is, again, the multi-platform trial looked at this. HEP-COVID did as well, and then 2 other studies, the COVID-PACT and Inspiration trials. The main difference with these studies, the only difference here is the Inspiration trial looked at prophylactic versus an intermediate dose of heparin instead of therapeutic dosing. And what you can see here is that in ICU patients, therapeutic dose heparin or even intermediate dose heparin was not associated with benefit. And what we saw in COVID-PACT is actually there was an increase in major bleeding. So the interpretation here is that for our ICU patients, prophylactic dose heparin is really what is recommended for those patients. So what about antiplatelets? And we've been able to study that also in Active-4A, and then another study out of the UK, Recovery, looked at that in a very large fashion, and COVID-PACT and the REMAP-CAP study did as well. And what you can see here, the first 2, the Active-4A and the Recovery study, really looked at non-ICU patients, and these looked at ICU patients. And for the most part, in non-ICU patients, in the Active-4A and Recovery study, did not show benefit. There was a suggestion of major bleeding increase in non-ICU patients that were treated with aspirin. However, in ICU patients, there is this signal here in the REMAP-CAP study that needs to be either replicated in some of the other studies that are ongoing. But it's interesting because they saw, despite not having an improvement in organ support, there was a survival benefit. But that survival benefit was not early in the course, it was at 90 days. So whether that's just an artifact or whether that can be replicated in the other studies is yet to be seen. There was a decrease in thrombosis that was offset, though, with major bleeding. So there is a cost. So really the interpretation here, we don't give antiplatelets in non-ICU patients, and really in ICU patients, it's at this point in time an unclear risk benefit. All right, what about at hospital discharge? And we've got two studies here. The Michelle trial has been published, and the active 4C study is coming soon. The manuscript has been accepted, so it should be out here very shortly. So in the Michelle study, they looked at high-risk patients treated with rivaroxaban after hospital discharge and saw there was a decrease in thrombosis. And that was a suggestion there, but there was not an increase in major bleeding, and there wasn't a change in survival. It was not placebo-controlled, and they used screening ultrasounds, so there is some question about the applicability of that trial across the board. So we will be getting additional information with the active 4C study. So really the interpretation there is to consider using anticoagulation for patients high risk for VTE and low bleeding risk. And this is what we saw also with any medical hospitalized patients. So this is sort of an extension of the studies that have already been done in high-risk medical patients too. So overall, this is sort of the visual picture of of the trials that have been done and sort of the implications of that. We don't use anticoagulation or antiplatelet therapies at diagnosis to prevent hospitalization or progression of disease. In hospitalized patients on the ward, we use therapeutic heparin, ICU, prophylactic heparin. Antiplatelets shouldn't be used for COVID reasons. In ICU patients, you can consider it. It's questionable based on that 90-day mortality outcome. And then in hospital discharge, really consider it with the data that we do have in patients that are determined to be high risk for VTE and low risk for bleeding. All right, the last lesson here is that our Bayesian clinical trial designs can answer our questions a lot faster. So the multi-platform study and that has been done, and the active studies have used these Bayesian clinical designs, and we have been able to use much larger amount of patients and get to the answers much faster. But the data is a bit hard to interpret. So I don't pretend to be a biostatistician, but I'm going to kind of talk through a couple of things. And so if there are any biostatisticians in the room, you can correct me if I get these details wrong. But kind of working through and being involved in each of the trials and using these different designs has given me a different insight to this too. So the frequentist design is what we're used to. So you calculate the probability. The probability is you're looking at, if you replicate the study again, how likely is it going to be? So your p-value, if it's less than 0.5, it's less than 5% that this is going to happen again. So the probability of having a more extreme result than your experiment. So if you have a low p-value, it's a low chance that it's a random result. But you have to, in order to get there, you have to set a sample size. And to understand, are you going to reject the hypothesis? Is this true or is this not? Now the Bayesian design works on probabilities as well, but it's your degree of a belief in the event. And the big difference here is you set things based on prior knowledge of what you expect, but also the current data set. So with Bayesian designs, there's massive computers that are constantly looking at the data and using different running different experiments to say, is this predicting your outcome? How likely are you to predict your outcome? How much, how likely are you to have an odds ratio greater than whatever you set it to be? And so you don't use these kind of null and alternative hypothesis. You just set your odds ratio, you gather the data, and that data then is used to sort of see, are we getting to that ratio? Are we getting to that point? Or does it look like this is going to be futile? And then you get to stop. So there's a flexible sample size with that, which then, again, leads to a faster, if the trial design is futile, you stop. And so you don't need to collect a huge sample size sometimes to understand that. However, now the translation of the results is easier, in my opinion, maybe because we're used to it, with the frequentist design. So, and I pulled the sort of, summary statement of the trials, and I'm pointing the finger at myself because I was an author on both of these papers, so I'm not pointing it at anybody else. So this is from the RAPID trial. So this is deaths occurred in 4 patients, 1.8% assigned to therapeutic heparin, and 18 patients assigned to prophylactic heparin. Odds ratio 0.2. There's your interval and your p-value associated with it. So the translation of that is that the odds of death were 78% lower in patients treated with therapeutic heparin. Now, with the Bayesian design, here's the summary statement. The posterior probability that therapeutic anticoagulation increased organ support-free days compared to thromboprophylaxis was 99%. It took me a long time to try to ask the statisticians. We had them explain this to us over and over and over again of what does this actually mean? And so really it kind of comes down to therapeutic doses of heparin increase the number of organ support-free days, but it's really hard to then translate what that odds ratio means because you're 20% more likely to be in this group than the other if you received heparin, but it is not as clean and easy to explain. So I think there are some future implications to that. And so for myself and any of the other clinical trialists in the room, I really do urge you, write your manuscript punchline. If everything turns out the way that you want it to be, what's your punchline? What's the CNN statement? What are you going to tell your patients about what this study tells us? And then to write also the guideline statement. What would you say, based on these results, we would expect and want to happen for any of our patients? And I think that may help us not have these huge composite endpoints that are really difficult to explain. It may help with trying to explain Bayesian designs or other clinical trial designs too. And to the funding, anybody involved in funding organizations or other things, there is always a lot of, innovation is obviously given a very large, impetus or, very large point increase in the grading scores, but sometimes a classically designed clinical trial's going to be able to be implemented. And so you lose points on innovation, but you may actually get your results implemented into clinical care. And we've seen that with the heparin results for COVID. People had a hard time understanding it and understanding the studies. And so the uptake of it has been less. So my plea to the funding organization is really value the ability to interpret the study findings, not only just fancy statistics or innovative study designs. With that, thank you so much for your attention, and we'll be able to take questions.
Start with some questions.
Hello again. I have a question for Dr. Paidas. So, Michael, in your studies, did you give SpikeNet beyond the same day as you gave as the viral infection, as the COVID infection? And if so, does it still work? And how many days post initial viral infection does it continue to work?
Yeah, thank you, Eric. Great question. So we gave it strategically and consistently. The model, we wanted to see the animal getting sick first because we were thinking clinically as well. That's what's going to happen. So we gave it once the animals were symptomatic, and we basically gave it 3 doses, basically every other day.
Okay.
We haven't gone to repeating yet, but that'll be down the road.
Okay. May I ask another question? You comment on the 2 neonates. Those are human neonates, right? The 2 newborns were
Yes,
human?
human.
There's reports that ACE2 and the other major receptor for the SARS-CoV-19 have decreased expression in children. How do you explain the viral entry under the circumstances? Is there some other mechanism for the fetus, for example?
Yes, so a great question. I think across the placenta, there's so much disruption, inflammation there that the virus is getting across, and then even though there's decreased ACE2, there's still some there, and I think that's what's happening.
Okay, thank you.
Thank you.
Thanks for great studies. Michael, an exciting model and an exciting therapy. I'm wondering if you have looked at any behavioral characteristics of these mice.
Yeah, thank you, Ken, for that. Yeah, so we actually did. I didn't show that, but we did we did a lot of behavioral studies, rotarot, many different ones. I just didn't present it.
So in the
Published.
survivors untreated, do they show significant deficit in cognitive ability?
Yes, so they do. My caveat is the long COVID study is small numbers, but they are not back to normal. They're like at a stage 2, and the animals in the acute phase that survive, they're not normal, but they're also like a stage 2 or so. Yeah.
And can the peptide have an effect in the long term on behavioral?
Yes. So in our preliminary work, yes, that's what we're finding. So, and now we're actually trying to extend that in larger numbers now.
Terrific. Thank you.
Thank you.
Lisa? Yes. Given how treatment of COVID has evolved and the virus has evolved, do you think these studies need to be repeated, or what can we understand from that?
Yeah, that's a great question. I think the biggest difference is with the variants and treatment with dexamethasone 2, we aren't seeing the severity that we saw early on. So I think the results still apply to people who are as severe as they were before. So we still do see some very rare patients that do get to that severity where you're going to be in the hospital for multiple days. And I think it's those patients. I think there's just less of them that are available now. And the other problems that we're seeing too is that the patients that we're seeing in the hospital now are either unvaccinated or they aren't responding to vaccines from immunocompromised states. So I think that there still is area for benefit there. It just is going to be potentially less. I don't think that the funding organizations are going to let us repeat it. To be honest.
Yes. John Bernstein, Penn State. It's kind of a combination question for both of you. Michael, you were showing in the lung disease 12 months what looks to me like pretty severe fibrosis that's ongoing as well. The 90-day survival on aspirin seemed to be better. That's probably because aspirin has a big effect on fibrosis in the lung through the PIK3A and the mTOR and AKT pathway. Is there a way, or have they thought about using any of the other drugs that have effects on those that might not increase the bleeding?
Which agents would you be?
We're using different agents right now along those same pathways for changing the vasculature in patients that have vascular anomalies and also increased fibrosis. So theoretically, those same drugs might have an effect in that group.
Yeah, very interesting. Yeah, there's the, so we can talk after, and I think that there's so many different aspects. The active studies have been kind of parsed into different areas. I was mostly involved with the thrombotics piece, but there may be some other of the other arms of that may be studying different pieces. So.
I neglected to say before in my comments that I want to commend both of you for wonderful studies. I think especially dynamite when you have, an animal model like a mouse model, that you could do things you can't do with humans and the human models to validate.
Thank you.
Yes. And let's see what, any other, okay, yes.
Hi, Richard Berwick, maternal fetal medicine. I had a question on the application to pregnant individuals. So where are we at on that? We take those tables and you look, most of those studies excluded pregnancy or they recruited but very small numbers. Do we apply that table to pregnant and postpartum, or often as OBGYNs we've shifted it towards an increase in anticoagulation? Is there any update on that?
Yeah, it's great today, or great question. And really, there is additional data there. So, it's really just the pregnant patients that are admitted, non-ICU patients, and have had a lot of discussion with our maternal fetal medicine and OBGYN colleagues on the guideline panel about how to handle that, because it's different if somebody isn't near delivery, but if somebody's near delivery, then how do you handle that piece? And really, there is a thought that in general we do apply most of the other agents that are used in non-pregnant people to pregnancy as well. And so it is applied there, but there's a lot of caveats then around the time of delivery.
Thank you, Richard. I was actually literally going to ask you this question about pregnancy, because we aren't giving therapeutic in the hospitalized non-ICU patient right now. I mean, as a general, the more sicker, yes, but obviously maybe we need to change that and bring it up, but we're not. Are you doing that?
No, we're mostly using a prophylactic. And
Yeah.
right, many patients are admitted incidentally discovered to have COVID, but you're right, the ones that are severe COVID requiring oxygen, then we would usually give them the prophylactic. In the very beginning, we were using that D-dimer. I'm assuming the D-dimer is dead. We sometimes use levels of D-dimer to help decide therapeutic versus prophylactic. Is that used at all, or is that done?
The difference, not specifically in pregnancy, but the one, the HEP COVID trial was the one that did enroll patients with an elevated D-dimer. So you had to be greater than 4 times the upper limit of normal, or greater than 2 or 3 plus another risk factor. So there are pieces of that does suggest that there still are, the D-dimer will predict sort of more severe disease. We have seen over the variants less D-dimer elevations than in comparison to Delta, for example. The D-dimers were sky high, whereas now we're not seeing D-dimers that are as elevated.
Can I just ask one follow-up? So we have a lot of patients that are on low-dose aspirin for prophylaxis for preeclampsia, like maybe half the population, more or less. Should we we normally keep people on low-dose aspirin for whatever's going on with them, I mean, minus a bleeding issue. So in this setting, would you recommend keeping it going?
Yes, yeah, so it really, most of these studies were excluded anybody who was on it initially, so will it be for preeclampsia or heart disease or whatever else, if they're on it, they should stay on it. But we wouldn't specifically start it for COVID.
Russell.
Hi, Russell Ware, Cincinnati Children's. I appreciated your summary of the data, but was also intrigued by your philosophy of how trials should be designed and endpoints and interpretation. And my comment is that now that the motivation and the money has dried up and the rest of us go back to going to study section and concept clearance, my own experience is that these are very regimented, templated ideas. And so, for example, if you try to do something innovative or different, it's not going to be well received and never even get to the study section. So my question was whether you think we're evolving as a result of all that's happened, although your interpretation was a little bit tepid in terms of it. What do you think about how we should design trials in the post-COVID era for more mundane, less dramatic things?
Yeah, in my experience has been the other way, that that if you don't go to study section with an innovative trial design, or you don't go with innovative innovative statistics, you get dinged for that, actually. And so I think that there is some room here, and it is different because they're also, so I've seen that, and I've also seen, for example, PCORI funding wanting very, much more kind of the COVID trials of like an established regimen against an established regimen with patient-reported outcomes. So I think that there's going to be differences depending upon which, what area of funding that you're looking for. I don't know that I have the answer to that, but I think that there needs to be, innovation's important, but there are a lot of sort of, we need to take into consideration how are we going to explain it. And if it's innovative and we can explain it, great. It's just I've seen where we haven't been able to do it, and then we've spent a lot of money on these studies, and then people aren't necessarily then picking up the results from it.
Thank you both. We'll have another short break and start back.